Good morning, good afternoon, good evening, wherever you are, and welcome to the 5th IFSO COVID-19 webinar. And today it's going to be a very interesting debate on restarting bariatric surgery. Delighted to have expert presenters and panelists. This webinar is sponsored by Medtronic. So thank you, Medtronic. Our debaters, Dr. Gerhard Prager, IFSO European Chapter President. Welcome, Dr. Prager. Dr. Mohit Bhandari from Mohawk Bariatric Center in India. Welcome, Mohit. And our panelists, Dr. Wendy Brown, our past scientific committee chair, our current president, Dr. Lillian Cow, and Dr. Jack Hempens, past IFSO president, and delighted to have Hazem Al-Momini as our communication committee member and the IFSO MENA communication committee chair as our fact checker. So discussing restarting bariatric surgery in the format of a debate. The debate will contain 5 questions to debate on. We're going to have polls to the audience that will precede each question. And the debaters will have 3 minutes each to answer first, and additional related rebuttals will be set to 2 minutes. Then we'll have the panelists share their point of view, and we'll see if the audience change their mind, influenced by the presenters or the panelists, and we'll ask our fact checker to check how we did after each question and add the data from the literature. And the audience, if they can type in their questions in the question format, we'll get to those questions at the end of the debate. So welcome everybody. As we all know, there's no consensus on how to restart bariatric surgery within the pandemic. And we know how the pandemic is growing. Currently, we have more than 5 million COVID-19 cases and more than 300 deaths. And the curve is still ongoing, but it's affecting different parts of the world differently. And everybody's talking about restarting bariatric surgery and restarting surgery in general, depending on where you are. And the main concern to us in the healthcare is asymptomatic patients and carriers infecting others. And the best practice guidelines, as we discussed, is to test all and take full precautions. And a negative PCR does not exclude COVID-19, as we all mentioned. And the guidelines adapt to the shortages that are present within the testing, PPEs, and the ability of the facility to start. And we know obesity is a major risk factor associated with COVID, and it's the second most risk factor for hospitalization in adults and the first in pediatrics. And we had conflicting guidelines. I know DSS guidelines discussed operating on the highest risk patients first in an expedited access format as opposed to standard. Meanwhile, the IFSO recommendations, which are hopefully soon to be published, discussed lowest risk patients and patients with younger age, lower BMI, controlled comorbidities, and I'll leave the details to the publication. Again, another IFSO recommendation by the endoscopy committee is to postpone elective endoscopy. Preoperative endoscopy should be postponed for 8 weeks. That's soon to be published, hopefully, in obesity surgery. And we don't have any other guidelines to resume elective endoscopy. So there are a lot of controversies. And the reality, and this is courtesy of Dr. Jack Hempens, is that we have hospitals that are dealing with cases currently, either suspected or confirmed, and these are numbers from Brussels. And you see the number of patients coming seeking operations all throughout. This is May data from Brussels, again, courtesy of Dr. Jock Hempins. The top graph is for operations and the lower graph is for office visits. So, and you can see that number alternating depending on the status. So if we can launch the first poll, Manuela, and in it, we'll ask the audience, are you seeing patients currently for elective bariatric surgery, either virtually or physically? Please answer. And I'll go to Dr. Wendy Brown. How are you doing, Dr. Brown, in Australia currently?
Look, we're very fortunate in Australia at the moment that the COVID situation hasn't been like the rest of the world. We did have an initial spike, but around Easter Sunday, our curve started to flatten and it went to drop down. So we've had very aggressive social distancing, and being an island, we were able to close our borders fairly early. So we've been fortunately spared. But what we haven't been spared is a loss of things like PPE. We live on an island and most of our manufacturing occurs offshore. So we haven't been able to get sufficient PPE. So both because of social distancing and because of lack of PPE, we have been seeing patients mainly virtually. And it's really only in the last week or so we've started seeing patients face to face. It is a little different in different areas of Australia, like where Lillian lives in Adelaide. They haven't had any COVID cases now for over 2 weeks. So they've gone back to more normal functions more quickly. But we are at the moment sort of seeing a combination of virtual and physical, and really only seeing the people physically that we don't feel we can deal with appropriately using telehealth or telephone.
And the audience, they're seeing patients virtually mostly, 39%, but only temporarily, and 28% doing both, and plan to keep virtual visits only currently. So let's close the results and go to our debaters. And delighted to have you both, Dr. Gerhard Prager and Mohit Bandari. If you can please just state your disclosures and case mix on what you do to begin. Dr. Prager.
We receive an educational fund and support by Medtronic and Ethicon at the University Clinic. That's it. Okay.
Dr. Bandari.
Yeah, so I'm on the advisory of J&J, Ethicon, Medtronic, and Intuitive Surgical, and Stryker Endoscopy. And we receive funding for research and grants from them.
Thank you both. So we'll start with Dr. Prager. How are you seeing patients currently, and are you seeing them virtually, physically, and will that affect your future plans? Please go ahead.
I work in Austria, in the very heart of Europe, and we had all over 16,000 cases in an 8 million inhabitants country with around 590 deaths. The current new infection rate is 50 cases per day in 8 million inhabitants. So we are already far beyond the peak. We're at the lower end of the plateau, let's say. So the surgeon, I am seeing patients physically, saying that we do the dietitian counseling and the psychological counseling by virtual means. I also have to mention that there is a big difference whether I see patients in my private practice or in the public system. Because here in Austria we face, as in maybe almost all the countries, that severe obesity is mainly a disease of lower social classes. So in the public, where it is reimbursed by the public healthcare providers, many of these people have a migrant background and do not speak the language properly or do not speak English. So it's very hard, or would be very hard, to do the counseling on a virtual basis. So I really have concerns in doing that in the public. In the private, it might be different. So to make the answer short, in the public, I see them all physically. we do parts of the preoperative counseling, not the surgical one, but the psychological and dietitian one virtually. And I think that we in the future will do more virtual counseling for sure, especially for the post-operative controls.
Great, thank you. That's very straight to the point. Dr. Bandari?
Yeah, so as far as we are concerned, the patients who come to our center are not from our city. We get patients from all parts of the country. And we are in the 4th phase of our lockdown. So we had the first phase starting from 24th of March. And now we are in the 4th phase, and just a week time remains till when the 4th phase is going to end. We have seen patients virtually only from 24th March until now. But this arrangement was made only until we have the transport for the patients to come to our city. So just recently, the trains and the flights have resumed from 1st of June. And that's when we will be shifting from the virtual mode to seeing these patients physically. So as of now, virtually, but shifting to the physical mode, we have prepared the outpatient clinic because we are a non-COVID treating hospital where we can maintain social distancing and we can maintain a separation from the patients and the healthcare professional. So this virtual mode will be just remaining 50% of our follow-ups, but we'll be seeing these patients physically starting 1st of June. As of now, the patient sees us only when he is about to get admitted for a bariatric procedure.
And you don't see them and the entire preoperative workup done virtually, basically?
The preoperative workup is done at our center. So the protocol which we are following here is that there is a lab which is situated inside the campus. It's not in the hospital, but it's inside the large campus we work in. And that lab tests the patient negative by a swab test, and the turnover time is pretty fast. They gives us results in 4 hours. And only then the patients are permitted to enter inside the hospital for further preoperative evaluation. So it's a different system. The patient will come to the lab first after he has agreed upon for a bariatric surgery, on the condition that he and his attender will have to give a nasal swab test in the lab where he's seated in an isolation. Once the results are declared in 4 hours and he's negative, there's no travel history, there's no fever, no history of contact, we would take the patient inside the hospital. And then a preoperative workup is done, starting first with a CT scan, a chest CT, and then we proceed further.
Great. So, and you know, we know there are risks currently within the pandemic as far as seeing the patient virtually versus physically, and some patients have certain fear, Dr. Prager, on coming and seeing patients. Are you seeing that? What are you doing to address those risks and fears?
We still, everybody that is admitted to the hospital is tested negative, and we do cohort testing for all the medical staff. So the risk to acquire an infection inside the hospital is very, very low. So this is my argument to the patient, to tell them that they shouldn't have any fear to come to the hospital. Saying that, we are a so-called COVID-free hospital. So we don't treat patients. We have one COVID positive ward just for cases that cannot be treated otherwhere, but this is separated entirely. And this is a 2,400 bed hospital, so the largest one we have in Austria.
Great. And Dr. Bandari, you mentioned those couple of issues, but are you seeing fear and from patients, and how are you addressing those fears?
Yes, so we have a very clear disclosure that, just like Gerhard said, that his hospital has a COVID ward, we do not have any COVID ward in our hospital. We are a complete non-COVID facility in the green zone. So as Dr. Prager said, we also test all our healthcare staff. In fact, all of us have gone through that tests, and we test them on a weekly basis after taking the history. So not only the healthcare staff, but the patients have to get tested, and the fear goes away because they don't see anything else happening here apart from bariatric surgeries. And also the assurance comes from the fact that they themselves cannot enter the hospital without being declared COVID negative on RT-PCR by a nasal swab test in the offsite lab, which is in the campus but not inside the hospital where the bariatric surgeries are being performed. That gives them a lot of confidence, because not only will the patient be tested, but the attendant along with the patient who has come to accompany him, if at all he has any, is also tested negative, along with a very detailed history taking, temperature screening, and making sure that they never had a contact, and only then they are permitted inside the hospital. So in short, both the healthcare professionals and the patients, if they are tested and you stress them about the test, they feel very secure.
That's great. And we'll go now to the panel, and I'll start with Dr. Cow. How are you seeing patients and addressing risks and fears virtually or physically?
So fortunately, I work in a non-COVID hospital. So even during the pandemic, when there was a lockdown in our country, many patients don't want to come to hospital. They have a fear that if they come to the hospital, they might actually catch the virus. So in that period, we were doing a lot of phone consults with our patients, and all our elective surgery was banned. So we couldn't prepare patients for surgery anyway. So there was a 5-week period where all elective surgery, including bariatric surgery, was banned. And in that period, we did a lot of phone consults.
And Dr. Hempens?
Yeah, well, we had a complete lockdown in the OR that lasted for 8 weeks. So from week 12 through week 20, there were only emergency cases, which included some cancer cases, but that's only in the real COVID positive hospitals like mine. In the other hospitals, when there were no COVID cases, I must say the surgeon twisted the law a little bit, and there were still hip replacements, and there were still carpal tunnels, and you name it, being done. But in my hospital, there was a complete stop of all elective surgery for a total of about 9 weeks. We started the procedures again on week 20, and for 1 week we did only cases that were called lighter cases, where the chances of needing to go to the ICU were very small. But as of last Monday, we started doing actually all comers, and we no longer made a difference with our practice beforehand. But I must say that all the patients, all of them are being tested. They're being tested within 72 hours before admission, and they're again being tested the day of the procedure with the so-called but less reliable fast PCR test. And only if both are negative, we proceed with the planned operation.
Okay, great. And Dr. Brown, you mentioned to us how you're doing, and you haven't restarted fully, but what are you doing to address the fears and of patients coming in?
So we did, as Lillian said, we saw about a 40% reduction in all presentations to hospital, which I think is common around the world. So there's a big public awareness campaign at the moment trying to reassure people that it's safe to come back to hospital, and we are seeing our numbers go up again now. We don't do routine testing before any surgeries. We're actually not allowed to. the epidemiologists tell us that the false negative rate means that it's not worthwhile, and the fact that we don't have very many of the rapid PCR tests yet. We only have the tests that take about, the Roche test that takes about 6 hours once it gets onto the run, means that it's not feasible. So we only test symptomatic patients or patients who come into the hospital. I work at a trauma centre, so if a trauma comes in that's intubated and can't give us a history. So we're really not doing, that's something that we're doing quite differently, I think, from the sounds of it, to the rest of the world. So we just do a symptomatic screening and a temperature test. And if they don't have any risk factors, then we proceed with normal precautions. If they have risk factors, then we'll use the precautions, the N95 masks and so forth.
Okay. And to all the panelists, we'll go back to Dr. Cal. Would you consider keeping virtual visits as a routine part of your practice in the future?
I think it's taught us a new way of looking after our patients. Some patients don't want to come in, some patients find it inconvenient to come in, and certainly that is one way of keeping in touch with our patients rather than not having any contact with our patient. But I wouldn't do that for all our patients, because majority of patients do like that face-to-face contact and the face-to-face interaction with their multidisciplinary team.
Dr. Hempens?
Well, there's a big problem here. You're here in Europe with GDPR, and actually we don't have the right to do a virtual consultation because there may be privacy issues. You never know if the patient that you're seeing on your screen is sitting alone, if there's people that are listening in, if on your side there are people listening in. So we're not yet allowed. The systems that are being developed would allow, would be GDPR conformed, but at this stage we can't. So when we were at the height of the pandemic, what we did when we needed to talk to a patient, we could only talk to them over the phone, not with with one of the video systems like Skype or FaceTime, if you name it. So at this stage, it's not yet operational.
Okay. And Dr. Brown?
Yeah, well, that's a very interesting point, Jas. We do consent our patients at the beginning of a consultation and get their verbal agreement that they're happy to have a consultation either by telehealth or telephone. I found it very patient-centric. It's a very patient-facing way of dealing with patients that you know well. So the patients I've been treating for 10, 15 years that I'm doing my annual catch-up with, it's actually, for them, their point of view, they don't have to drive in, they don't have to park, they don't have to leave work even. But for new patients, I found it much harder. And in fact, I haven't accepted that as the first consultation. I'll make sure I see them face to face and go through things again, because I think that relationship is much harder to establish over the telephone or even with the video.
That's, those are all great points that you raised, technical and non-technical from a surgeon side and a patient side. So let's launch our second poll. And let's see if the presenters or the panelists changed your opinion on any of the above note. And I'll go to Hazem meanwhile. Hazem, how did we do in the first? And what can you tell us that we didn't discuss?
Good day, everyone. Interesting discussion. Listening to the various members of the panelists and debaters, you can see the variation of the practice across the world. Obviously, there are cultural factors, economical factors, and service-related factors that need to be considered. I think listening to you all, if anyone can do anything differently, I would like to congratulate our colleague from India for what they're doing. I think reading through the evidence, if combining CT scan and PCR, your sensitivity can reach up to 99% to detect asymptomatic COVID cases. This has been published in the Radiology Journal, an article from China earlier this year in February. However, this is a luxury that not everyone can achieve. I can't imagine myself going to my hospital, asking them to do a CT scan for every elective admission I need to do. we seem to be doing what the majority of the others are doing, as in doing the swabs. But I would like to congratulate them. Combining CT scan and the PCR would achieve the maximum sensitivity anyone can achieve. But other than that, I've got nothing else to add. Thank you.
Thank you, Hazem. Let's close the poll and see the results of the audience. And 60% say already offer virtual visits and will keep them in the future. And 26% we managed to change the mind of 30%. 26% said that they would consider virtual visits. 4% said they wouldn't consider it anymore. So depending on your location, it'll be interesting to correlate the results. So let's go to our second session. And with it, we'll launch the third poll to the audience. What will you adopt as a strategy to accept all comers as far as patients, risk factors, or start selectively, like the IFSO guidelines? And the DSS sort of talks about higher risk, while IFSO talks about lower risk patients. And I'll go to Dr. Jack Hempens. What are you doing within your practice currently, selectively or accepting all comers?
Well, there's a difference between my own practice and the guidelines. Actually, the guidelines are that we should not make a selection of patients and actively spare, if you will, the sickest patients. But that's what I actually do in my practice. I postponed the patients that are considered the ones that need priority treatment by the DSS. Well, they're the ones that I would like delay for about 3 months. And what I'm doing now is the so-called lighter cases that in the Cleveland Clinic, actually, they would call the tier 1 or tier 2 patients. And I'm really trying to avoid to have the patient stay in the hospital too long. I avoid a theoretical risk for them to have to go to the ICU. So I will sit tight and watch what happens and just start my regular practice in, I would say, like 3 months.
Great. So 57% agree with you, Dr. Hempens, that they operate only on low risk patients, and 11% are undecided. However, 18% are doing all comers, and 15% agree with the DSS, and they are doing higher risk patients in need to begin with. So let's go to our debaters and see what they're doing in their practice. And I'll start with you, Dr. Bandari. Please, what are you doing?
Yeah, good evening. So we are doing each and every case. We are not selecting cases. And I sort of agree with the DSS guidelines that those are the patients who are at very high risk, super obese patients with a higher BMI, severely diabetic patients. They are at more risk, if at all we see as the new normal. So we have selected algorithm at our center, and we have not changed anything except for, as I said, very vigorous protocol to pre-operatively evaluate these patients with RT-PCR and CT chest, and completely ruling out possibility of any disease. We do not select between patients as low risk, high risk, or medium risk to operate upon them. I would personally feel that patients who are severely diabetics, when they had pneumonitis, even without COVID infection in our country, had very poor outcomes. Patients who are obese, and there are certain patients who are obese who had pneumonitis during the COVID season without actually having the COVID infection, also had more morbidity. So I realized that once the lockdown opened, these are the high risk patients the super obese, the severely diabetics, the critically ill patients who would be more exposed to the viral pandemic and therefore needs metabolic and bariatric surgery, rather than the ones who are low risk or lower BMIs who can still manage with some lifestyle modification.
Okay, let's go to Dr. Prager and see what you're doing.
I think we have to differentiate it a little bit. In the first phase, when we started doing bariatric metabolic surgery again, we did those cases who had more urgency, saying that this means like doing a new anastomosis due to ulcers or revisional cases due to suspected internal hernia. So we started with these cases, and then in the second phase we started with people that were had a well-controlled diabetes, so somehow contrary to the DSS guidelines. Of course, I read the DSS guidelines, but when we consider the amount of patients with severe obesity, the view we operate now in this time will have no impact at all at the probability that these patients will become COVID positive and suffer less, or will be healed earlier, or be asymptomatic, or anything like that. So now we are in a phase where we do not select anymore at all. We run now around 75 to 80% capacity, and we will change to 100% in 2 weeks. We also run a COVID suspect ward here at our hospital. And I can tell you the most common situation was patients who were PCR negative and had a suspicious CT scan. And the probability to become PCR positive, although we did serial testing, was very, very low. So we have a very different experience than the people in China, where the CT scan was highly predictive. So we do not do a CT scan on every patient. We just do PCR testing, and at the time of admittance and 48 afterwards, 48 hours after.
So basically, I think both of you are at the stage of accepting currently all comers and not being selective. And I'll go to Dr. Bandari. I know you're aggressive at screening and doing PCR and CT scan, which I would assume the best available. But what if you have a positive patient that post-operatively after? How would your facility deal with that situation?
So what we are doing now is that when we are operating a patient here, we first of all ask that patient to maintain strict home quarantine for 15 days. And then we request him to get a RT-PCR done after 15 days after this procedure. At this point of time, this is our standard of care. If the patient still turns out to be positive, and that is a situation where we missed it when we operated, the entire team will have to be quarantined in that particular case. That has not happened to us, but as an imaginary question, if still, despite these precautions, we still have a positive patient after getting a surgery from our center, we have to follow the protocols of the local administration, where the entire team has to be quarantined and has to be tested, number one. Number two, there is something which we use here, which is known as a gene expert test, a TrueNet, which has the highest negative predictive value. So gene expert is something which the publications are coming. I'm not talking about the RT-PCR, but I'm talking about the gene expert, which is a TrueNet with a highly sensitive HRCT, rules out 99.9% cases for us at this point of time. We've been successful in doing those cases. So I think that could be a response to what the question you have asked.
Yes, congratulations on what you do, actually. Dr. Prager?
Sorry, I missed the question.
So the question is, I know you're taking precautions and testing everybody, and you know, there are limitations to what we do, but what if you have a positive patient within your practice at the current situation? What are your precautions? What do you do?
So as I mentioned, we test the patient at the time of admittance. There is no time lag between the PCR test and admitting the patient to the hospital. So when the patient enters the hospital, he has the swab test and is isolated until we have the result of the test. And then he is transferred to the ward. In the ward, we have a maximum capacity of 2 people per room. So we have no more 3 bedrooms, or we don't have more than 3 bedrooms. So the maximum is 2 patients per room. And they get tested another 48 hours after admittance, second test. And if they have to be transferred to another institution, they have a 3rd test before transferring them. If we would have a positive patient inside the hospital, which we didn't have until now, we of course would have to go into quarantine. We do serial testing for all our medical staff every week. So you can see I have big nose holes already because every week I get a swab test.
Well, yeah, that's a potential hazard of working and operating currently within these situations. So I'll go to the panelists now and start with Dr. Lillian Cao. Dr. Cao, what are you doing? Selective, all comers, and how are you addressing potential positive patients within your practice?
So I think the strategy of starting elective surgery really depends on your local hospital and the availability of PPEs. When we started, we were told that we can start at 25% because we still had limited PPEs. So based on that, we were selective. We choose the lowest risk patients. So we got them in, got their operation, they got out as quickly as possible, and there was low risk of them being admitted to the intensive care or requiring PPEs in case that there was COVID positive. But now that the situation is getting better, our ICU is better equipped, we've got more extra beds, we've actually moved the other way and we're non-selective with our patients. So we take all comers now.
Great. And potentially, if you have a positive patient, are there protocols to follow? And if they are, could you share them with us, please?
Yeah, so if we've operated on a patient that we've screened and then we find that the patient is COVID positive after the surgery, then of course the patient will have to be transferred to a COVID hospital because our hospital is non-COVID, and the whole team and the whole unit will of course have to be in quarantine and self-isolate and not come to work for at least 2 weeks.
Okay. Yeah, Dr. Brown?
Very similar to Lillian, and I echo what she says about local resources. We've had a mandate from our government when we went to 25% that we could only do high value, low risk procedures. So value is a very difficult thing to define because what's valuable to you is probably not the same as what's valuable to me. But we've interpreted that as people who are in the BMI group, not over 50, who have a comorbidity that's likely to be reversed with bariatric surgery, but is still a low operative risk and still low likelihood of needing an ICU bed because we are trying to preserve ICU capacity around the state in case we do get this surge of COVID patients. And I think we're very fearful of a second wave and how bad that may be if you look at overseas experience with other influenza type situations. But if there was a positive patient and that's happened in our hospital, everyone goes on furlough for 2 weeks. So the consequences of an unintended operating unintentionally on someone with COVID is bad for the patient because we know their morbidity is much higher than if they hadn't had an operation, and it's bad for the system because everyone has to be furloughed.
Thank you, Dr. Brown. Dr. Himpens?
Well, what happens when we have, it's very unlikely that 1 of our patients would end up being COVID positive after all the screening that we do. And in the theoretical or the hypothetical case, we would we would quarantine, I think, we would not quarantine, I don't think, the healthcare workers that came in contact, because all the precautions are actually still being taken during the cases. And so we're still trying to, for instance, intubate the patients with a fibroscope. Everybody is wearing full protection, full PPE. We're trying to minimize the number of participants in the ORs. We're trying to keep the same safe ways, if you will, for the patients to be transferred from one place of the hospital to the other. So I don't think that there is actually a need for quarantine if by accident there still would be a patient that turned out to be COVID positive. On the other hand, on the patient side, when that would happen, I think we would certainly place a patient, of course, in a COVID positive ward, which we still have. We still have a floor that's dedicated to that, but with a very low threshold for transferring that patient to the ICU, because as Wendy pointed out, we know that the morbidity of patients that are COVID positive for whatever procedure is much higher, and even mortality is much higher than for other patients.
And one thought, and I think part of the some facilities are practicing it. Would you consider having more than one team dealing with patients for a certain period of time? Let's say one week on one team, team one, team two would be on the following week, and having a team three, but you need additional staff to, to coordinate, and then you would have each team being quarantined for 14 days. Meanwhile, if you have 3 teams operating on patients, Dr. Cow, do you have any thoughts?
Well, in the public hospital, when were dealing with emergency patients, each surgical unit had to do separate ward rounds. So we divided each surgical unit into 2, so that one half will not meet with the other half, just in case that particular surgical unit got infected. That at least that surgical unit is not completely washed out for 2 weeks.
And Dr. Brown?
We did the same thing. We split our units, but we also had a roster ready to go if the numbers had continued to escalate, where we pretty much, as you described, we're in teams where we were sort of 2 weeks on, 2 weeks off, and we were separated into roles in theatre, emergency department and intensive care, so that we tried to keep teams distinct and allow for a backup plan that if teams do get infected. Luckily, we didn't need to institute it.
Hopefully nobody would. Dr. Hempens?
We actually did that when we were at the peak of the pandemic, but since the numbers started to decline, we no longer do that. But we needed to do that because at one point we really had, I think we had 100 COVID positive patients in the hospital.
Okay, so let's go to the audience and see if we manage to change their opinion. And meanwhile, I'll go to Hazem. Hazem, how did we do?
Thank you, Ahmed. I think the second question once again shows the diversity of the approach and management depending on the resources, the type of hospitals and the practice. I think once again, Dr. Pandari is probably achieving the best anyone can achieve. He was talking in his answer about the genome subtraction testing for SARS. I mean, there isn't much published data about this, but all the published data would show this is probably one of the most sensitive methods, with nearly 100% concurrence with regard to the diagnosis of COVID. Other than that, I can see that the practice varies from one country to the other. There are huge variations, similar to what we see as well with the DSS guidelines and what IFSO is planning to publish recently. And that's just about it, please.
So let's see what the audience think and if we manage to change their mind or not. And 49% remain selective, only low-risk patients, and 12% would operate on high-risk patients, while 13% will switch to low risk instead. So that's where we stand. Only 15% state remain business as usual. So let's move on to the following poll. And will your preoperative bariatric workup change? Are you going to do preoperative endoscopy routinely or selectively? And I'll go to Dr. Brown. I know we've been working on the endoscopy position statement before bariatric surgery, but within the pandemic, what are you doing and how you're approaching preoperative workup, specifically endoscopy?
So I'm sort of following the guidelines that we'll be publishing soon in obesity surgery still. So for symptomatic patients that we know there's around a 26% chance that there'll be a pathology that, or 14% chance, sorry, that we'll find a pathology that may alter our treatment, or people that have a known history of any sort of pathology. I would definitely do a scope. And if I'm doing a procedure that's refluxogenic or one that I'm going to be excluding part of the stomach, I would do a scope. But we're working in an environment where the background rate of COVID is very low. So we've recently done 150,000 asymptomatic tests in my state, and there was only 2 positive patients. So we're not working in a high-risk environment. So I'm taking the approach at the moment that if I'm going to do the surgery, I'm going to do it the way I think is best for my patient. And if that includes a preoperative endoscopy, then I'll certainly do that. But if I was working in a more, where COVID was more prevalent, then maybe I would be thinking about deferring the endoscopy, but therefore also deferring the surgery until I felt that it was safer to proceed.
Great. And as far as the audience, 32% they're selective and will remain selective. 41% routine endoscopy for all, which is a good number, and 7% selective and will stop offering it at all. That's a concerning number. I usually offer routine endoscopy in 15% and will become selective. I usually offer routine endoscopy but will stop completely is 5%. So it's variable, but majority are between routine and selective endoscopy currently. So we'll go to the debaters now, and let's see, Dr. Prager, how are you approaching your preoperative workup and endoscopy?
So to start with endoscopy, we always did routine preoperative endoscopy on all our patients, and we are still doing that, and we will not change it. Saying this, we test all the patients before doing the endoscopy, PCR testing, and the people doing the endoscopy wear full PPE protection equipment. So we try our best that there is no enhanced risk for the medical staff if we miss somebody. As I can tell you, until now, as we do serial testing, because if they have the endoscopy, they have one test and another test when they are admitted to the hospital. Until now, there was not a case where a patient became positive. So I'm with Mandy and Lillian. Also in Austria, the prevalence of COVID at the moment, I would consider to be rather low. Concerning the preoperative workup of the patients, what has changed is that the dietitian and psychological counseling is done more often on a virtual basis. I think this will stay in the future. Me as a surgeon, I want to see the patient physically. This is for me a mandatory thing.
Those are great points. Thank you, Dr. Prager. Dr. Bandari?
Yeah, so here I would agree with Dr. Prager, and we have not changed our practice a bit. We will do preoperative endoscopy in all our cases. because as he said, first we are testing all of them before even entering inside the hospital. Second, when we leave no stone unturned in testing, we also provide our staff with complete personal protective equipment while doing an endoscopy. And something which we made after seeing others is that we completely cover the face of our patient by a hood while doing an endoscopy.
Wow.
So I think the operative testing, having full PPE and completely covering the patient by a intubation hood while doing an endoscopy, it makes complete sense in not changing the way we practice. Endoscopy, I think, is a very, very integral part of bariatric surgery. And I think we all should do it as a part of our workup, even in the post-pandemic era. Having said that, we have also not stopped the therapeutic endoscopies for complications of bariatric surgery, as in removing an eroded ring or putting in a stent or removing a balloon. We have been doing that even during this phase with proper preoperative testing by RT-PCR, TrueNet gene extraction, and CT chest, personal protective equipment, and complete hood cover for all our patients. So I would not change my practice, and we would continue to do it regularly.
So we have a unanimous agreement on the necessity of preoperative endoscopy. For those who are concerned in the audience, Dr. Prager, about doing preoperative endoscopy, despite feeling that it is necessary just for the sake of, let's say, possible viral transmission, would you consider or advise doing endoscopy in the OR immediately preoperatively after intubating the patient, or not, as a way to probably, hopefully, decrease the times that the patient have to go through aerosol generating procedures?
I think this is not the best option. As Mohit already mentioned, we also do it only preoperatively. If you really have concerns before doing nothing, this is still a way to do it. But you have to keep in mind that what you see during endoscopy, which means inflammation or CLE tanks, does not always reflect the histological finding. There's pretty often a discrepancy between it. So what you can consider is hiatal hernia, severe inflammation in the stomach, polyps, etc. So before doing nothing, I would consider doing it intraoperatively, but you need the consent of the patient that you might change the operation method.
That's a great point, definitely. Dr. Bandari, what do you think about immediate endoscopy right after intubation?
I think that's a great idea, and we actually have a lot of data on doing immediate preoperative endoscopy on the table. But as Dr. Prager said, very important, we should take the consent of the patient that if we find an esophagitis or something, we might change the type of procedure we're going to perform. That's very important. I think if we have a good consent, that the procedure would depend upon the endoscopic findings and might change. I think it makes a lot of sense to do all these endoscopies inside the operating room. So we save the cost of the personal protective equipment, specifically for a country like India, where we are a little concerned about the cost. We save the cost of the personal protective equipment. Plus, I think we are much more, we decrease the aerosols coming out of the mouth, because I know that most of us who are performing endoscopies in OPD basis, the patient is not completely put to sleep. It's done in sedation, where the patient will do some bugging and he can throw more aerosols outside. So when you are doing inside the theater, as Dr. Ahmed said, the advantage is that you are completely knocking off the patient where he's intubated. And to do an endoscopy in a patient intraoperatively or just preoperatively on the operating room table when he's intubated produces much less aerosols as compared to when you're doing on the OPD basis. But as Dr. Praj said, you need to have a good consent. If you find an esophagitis or a large hiatus, you may refrain from doing a sleeve as your algorithm suggests.
Great. Those are great points as well that you raised. Thank you both. And I'll go to our panelists and start with Dr. Hempens. How are you approaching your preoperative workup, specifically endoscopy, in your patient population?
Well, first of all, I would like to respond to what I just heard. This is in an ideal world. I mean, there's no way we could do on the table immediate preoperative endoscopy, because for the simple reason we're not doing our own endoscopies. We have to rely on gastroenterologists, and I cannot imagine that they would come over all the way to the OR, 6 times a day, and that's something that's just not going to happen. But to answer your question concerning the need of performing endoscopy, I think that we have to think on the long term. And I know we are in a difficult situation right now with that COVID situation, but we cannot, I don't think, deny our principles of bariatric surgery. And these include mandatory, I would say, preoperative endoscopy for the several reasons that have been mentioned in the IFSO position statement. So I think that we should take all the necessary precautions, but still perform endoscopy on all the patients preoperatively.
Great. Dr. Cal?
So our practice has been always to do preoperative endoscopy, and we haven't changed this in the pandemic. Apart from the fact that when elective surgery was banned, we couldn't do bariatric surgery, therefore we couldn't do any preoperative endoscopy. I don't support doing endoscopy when the patient is intubated, because it takes out the consent from the patient. If you find something, how are you going to discuss with the patient what you're going to do? I think that's not an ideal place to have your patient leave everything to the doctor or the surgeon to decide what operation they get just based on an endoscopy.
And assuming all these limitations are discussed with the patient preoperatively, Dr. Brown, would you, in a place which is short in PPE, short in testing, and have all these limitations, accept the preoperative endoscopy as a tool to help guide you what to do?
I'm sorry, I'm not sure what you're sort of getting at. Are you asking, would I go?
If you have, in a place that is have shortages in PPEs, testing, all that, and you're not considering doing a preoperative endoscopy just because of those reasons, would you consider intraoperative endoscopy as a substitute?
For all the reasons that Jacques and Lillian mentioned, I think the patient is critical in this. This is a team sport. Bariatric surgery is the ultimate team sport, and the captain of the team is our patient. And so if we take that power away from them from the beginning, I think we're starting out on a very bad foot. And if we don't have enough PPE and we don't have enough resource to do gastroscopies, I suspect we probably shouldn't be doing bariatric surgery either. Bariatric surgery is a fantastic long-term tool for helping our patients achieve and maintain very good weight loss. But if they have to wait 3 months on a very low-calorie diet, that's probably not a bad alternative if the other option is to compromise a good bariatric procedure.
Okay, those are all excellent points, and I think we've answered the majority of the realities concerning preoperative endoscopy, its importance, the approach, and let's go to the audience and see what they think. And meanwhile, I'll go to Hazem.
Thank you, Ahmed. All the published evidence is against doing endoscopy unless you need to, and should you decide to go with the endoscopy, all the PPE should be taken into account. I mean, listening to the speakers, is once again, you can see the diversity of practice from one part to the other. If you look at the example Dr. Brown has given, she seems to be living in a part of the world where the possibility of infection is very low, and that can justify what she's practicing. Then you move on to Dr. Pandari. He's talking about his practice where they rigorously screen all these patients, so the likelihood of anyone being positive is also negative. What everyone is in agreement is that endoscopy is a very high-risk procedure. It's a high-risk procedure to the medical team in particular. Figures published from the north of Italy support this. They've had high infection rates outside ICU and the COVID wards, mainly from endoscopy. So all the necessary precautions need to be taken to protect the team. But other than that, I think everything that was stated is accurate considering the circumstances where the different surgeons are practicing.
Thank you, Hazem, very much. And let's see what the audience think, if we manage to change their mind or not. And 42% still will continue to be selective. 41% will keep offering routine endoscopy, and only 17% will either stop completely, become selective, or do endoscopy after intubation. So let's move on to the next poll. And given that a lot of the audience does selective endoscopy, would you change your procedure recommendation if you choose preoperative selective endoscopy and not routine endoscopy? So I'll go to Dr. Hempens on this one. Would if you're not doing endoscopy or doing it selectively, how would you approach your procedure recommendation within these limitations? I know you're not, but if you are, would you change your procedure recommendations?
Well, as you said, no, I will not change my way of thinking, and I will continue doing endoscopies. But in the, again, hypothetical situation that there's no endoscopy available, I would certainly do procedures, only procedures that do not have mandatory endoscopies in the follow-up. And those are, again, according to the position statement of IFSO, those are sleeve gastrectomy and single or one anastomosis gastric bypass. So those I will no longer do, because I really think that it's absolutely essential to do endoscopies on the long term in those patients.
Okay, let's see if the audience agrees with you or not. And 44% will not offer any procedure without endoscopy. So they're agreement with everyone. 25% will offer routine endoscopy or counsel on risks without endoscopy. So that's an option that is considered well informed. So let's go to the debaters. And Dr. Bandari, I know you're doing routine endoscopy, and that's been your stance within your practice, but if it is up to you and you're short and you have to do selective endoscopy, how would you approach your procedure selection?
So that's a very difficult situation to be in. As I said, I think first we are doing endoscopies at our center ourselves. We don't need gastroenterologists, and the hospital privileges are with us to do the endoscopy. So having given that opportunity, I think I would still like to say that I will do preoperative endoscopy and would not change the way I practice. We have an algorithm where we divide our surgical procedures in bariatric surgery into one anastomosis, sleeves, and gastric bypasses. And the 3 procedures have got 3 very distinct indications, which have been backed up by sound surgical practice and evidence. So we do not offer a cirrhotic patient a mini bypass or one anastomosis. We do not offer a GERD patient a sleeve, and we do not offer a diabetic patient with GERD a sleeve, or a young unmarried female without diabetes a gastric bypass. So all the principles we made in bariatric surgery have been made because of some evidence which was governed by other factors rather than COVID-19 pandemic. So again, here I would disagree. I would try to scan my patients, do very aggressive monitoring, screening, do endoscopy, and without endoscopy, I won't touch these patients, because if I practice empirically science of bariatric surgery, I don't think I'll be doing justice to my patients. I'll stick to my algorithm and do endoscopies for all my patients. And if I cannot, I won't operate.
Great. Dr. Prager, what would you do?
We have pretty the same approach that we did and do endoscopy in all patients. Given the task that we have to do it selectively, I would think of other modalities to look for hiatal hernia and reflux, which include video kinematography or even more fancy dynamic MRI of the gastroesophageal junction. And if you have an experienced radiologist with a doing very good video kinematography, I think you can, to a pretty good rate, exclude reflux disease. So this could be an option. Also, it is not the best to offer to these patients also operations that are of course of concern with reflux, which means sleeve gastrectomy and one anastomosis gastric bypass. We do the endoscopies all ourselves. I do, for instance, if I want to check an anastomosis, I do it myself in the OR. We do the stents ourselves and everything, all endoscopic procedures. And I think this is something very valuable if we surgeons are able to do endoscopy.
Great. So we're all in agreement that without endoscopy, you're sort of blinded and you need more information. So if you have approached that selective approach to endoscopy, and patients are still insistent, I want this procedure despite the risk, how would you counsel those patients, Dr. Bandari, within this time frame, pandemic? What do you tell them?
Yeah, so we have a pretty different system. Like Lillian said, there's a lot of patient involvement in deciding upon the procedure. We don't offer procedure the patient wants to get. We offer the procedure which is the best suited for this patient, because patients have limited knowledge. They have limited data, but we as bariatric surgeons have gone through a lot of data, and then only we devise our algorithms. So I would explain them that, see, this is the data suggestive that sleeve causes reflux, and if you have GERD already, these are the complications which happen. So at our center, we have the algorithm, and there is a logic behind that algorithm which is explained to all our patients. If a patient who has cirrhosis undergoes, or he would stress or force us to do a mini bypass or a one anastomosis, we're not going to do it by telling him the data about the liver failures. If a patient who has severe GERD wants a sleeve, we're going to give him a data about the incidence of de novo GERD and severe esophagitis and Barrett's after a sleeve. So that's the part of our counseling. And if the patient does not agree, I don't think we should operate upon patients with the choice of patients wanting a procedure. I'll offer what I think is correct for the patient rather than patient coming with a demand for a procedure.
Okay. Dr. Prager?
I think you must make again a difference between public healthcare system and private healthcare systems, because if you get paid by case, your opinion might be a little bit more influenced than when you work in a public healthcare system. and I do work in a public healthcare system, so I stick with Mohit. If somebody suffers from clinical reflux GERD, I will not do a sleeve on him. He must seek for another surgeon. And I assume in Austria it will be pretty hard to find a surgeon doing on such a patient a sleeve. At least that's what I hope. Yeah, so I'm quite same opinion as Mohit. According to NASH or severe cirrhosis, the problem is that you often do not have the diagnosis of cirrhosis or severe NASH. You see it during the operation. Saying that, all our patients sign that we are allowed to change the operative procedure during the operation. So they have consent that we, if they're scheduled, let's say for a one anastomosis gastric bypass, and we see severe NASH during the operation, severe fibrosis or cirrhosis, we don't do any procedure that excludes a bigger amount of small bowel.
Okay, and those are excellent points. And to the panel, I'll go to Dr. Cao. And how would you approach patients or counseling patients if you're doing selective endoscopy, not routine? I know everyone is doing almost routine endoscopy. And how would you approach a patient coming to you insisting on a procedure versus the other, and let's say refusing even to do endoscopy within this pandemic period of time?
I think our patients are a unique group of patients, and we shouldn't compromise for these patients. We are the experts in bariatric surgery and metabolic surgery, and we are in the best position to advise the patient what is best. So if we feel that the operation is not suitable to the patient for whatever reason, then I don't think we should put ourselves in the position to give the patient what they want. We have the data, we have the information, and we can always tell a patient why and all the reasons why the patient should have one operation which is more beneficial to the patient than another. So I don't believe we should compromise at all, whether a patient is in private, public, or what they believe.
Dr. Brown, if a patient comes and tell you, I understand the risks that are present. I understand, I am aware of the data of, let's say, Barrett's esophagus that comes after sleeve gastrectomy, possibly or potentially. I want a sleeve gastrectomy without an endoscopy. What's your approach?
I don't think it's too dissimilar to the others. I mean, I do believe in shared decision making, and as I said before, I think ultimately this is the ultimate team sport, bariatric surgery. We get to know these patients very well over a long period of time, and they really do have to be captains of the team and prepared to take on all the lifestyle changes that go with the operations that are really just a tool for them to maintain this weight loss. And so, but I also think, take the point that people can read literature and lay people can be influenced. Their reading of the literature may be a little bit different to our training. And obviously Facebook and other forums have a very big influence over what they believe to be the best treatment. And so we have to be professional, and we do have to care for them and give them good advice that we think, that we feel that we can defend into the long term, because we're going to be looking after them into the long term. So I wouldn't go ahead with the procedure just because a patient was insisting on it, and I wouldn't compromise the care that I believe they need just because they were insisting on it.
Dr. Hempens, would your approach be any different?
I completely agree with the previous speaker, because I mean, it's always been my policy that the patient, I don't think it's the patient's wish that we have to follow. We can listen to the patient, but eventually, like Dr. Bandari said, we're the ones that decide, because we're the ones that know what the risks are of what we do. And just like a patient will not tell you what type of antibiotics he or she wants for, say, pneumonia, just here for the same, for the condition of obesity with possible comorbidities, I think you're the surgeon is the best placed to decide.
Great. So we're all in agreement on this point. Let's see what the audience feels in our next poll. Did we change your mind? Please go ahead and answer, and I'll go to Hazem meanwhile. Hazem, how did we do?
Thank you, Ahmed. Not much to say. I've only got a comment about some of the tests that were referenced by Dr. Praga. He made reference to the real-time MRI, which is a dynamic assessment of the gastroesophageal junction. This is a recently described method to assess for gastroesophageal reflux. However, one needs to be careful that this method of testing only tests for reflux, but it doesn't tell us if it is acidic reflux or non-acidic reflux. In a recently published article, what they found is about 66% of the, 45% of these patients did have acid reflux, but 60% did in fact have bile reflux. So this test will tell us that there's a reflux, but it won't be able to tell us what type of reflux it is. So it may be considered as an adjunct in addition to the endoscopy, but I'm not sure it will be able to completely replace endoscopy as a diagnostic method for gastroesophageal reflux.
And I think Dr. Prager agrees with you, definitely. Great. So let's close the poll and see if we manage to change their mind. And 59% still offer all endoscopy or counsel on risks without endoscopy, and 14% would offer less sleeve gastrectomy or one anastomosis without endoscopy, and 11% will offer all procedures without endoscopy still, and 11% will remain on less sleeve, one anastomosis, or any type of bypass without endoscopy. So let's move on to the last poll. Will you continue to take precautions in patients with COVID-19 negative status? And when will you test patients for COVID-19? And I know we alluded to it a little bit, but let's discuss it in details. Dr. Cao, what's your approach currently?
With all our patients that come to hospital, they are screened with a questionnaire and their temperature. And while they're low risk, there are some precautions we still take within our hospitals, such as social distancing and also PPEs. When will I test patients for COVID? Of course, the ones with high risk.
And when do you actually test them? Like on the day, 72 hours? Some do admit patients, quarantine them, and test them. What's your approach now?
So in our country, which is a low-risk country, based on the questionnaire and the temperature, if they're all negative, then we don't actually test them for COVID-19.
Oh, you don't? Okay. So you only test high-risk patients. Okay.
Correct.
Great.
Or it's also been suggested that if we test every patient that came in for elective surgery, then we will run out of test kits in the country.
Okay, good reason not to. So let's see what the audience does. So 48% yes, they would use standard PPEs with filters and testing 1 day prior. 20% standard PPEs with filters and test any time prior to the procedure, and 15% on the day of surgery. They must have rapid test results. So let's go to the debaters and see what they do. Dr. Prager, so when do you test patients, and what are the precautions that you take in the operating room in a COVID-19 negative patient?
So we do test all patients at when they are admitted to the hospital with a PCR test. They are then isolated until we have the test result. We have different speeds of testing. If it is really, let's say, urgent, we have a result within 60 to 70 minutes, and the normal test result takes around 4 hours. We test the patient the second time after 48 hours. And if some patients are transferred to other institutions, they are tested for a third time. In the OR, we use the normal PPE equipment. We do not use FFP3 masks. Even the anesthesiologists do not use FFP3 masks in PCR negative patients.
Let me ask you as well, do you take any precautions when operating, as far as filters, instruments, specific instruments, energy sources in a negative patient? Or
this is an excellent question. There is, I would say, the evidence to avoid, let's say, ultrasonic devices that might are more aerosol producing. There are some hints, but in my opinion, the evidence is not really there that you have a higher infection by that. Smoke evacuation, I think you can implement that in a very cheap way. You don't need to have very fancy devices. I won't expand on that, how to do that right now. We did an IFSO EC webinar just dedicated to this topic a few weeks ago. So yes, these precautions we do take.
Okay. In negative patients as well?
Yes.
Okay, great. Dr. Bandari?
Yeah, so as Dr. Prager said, we are a COVID-19 negative facility, which means that the patient will only enter inside the hospital once he is declared COVID-19 negative by a test. I have been mentioning an off-site lab, which is in the campus but away from our hospital, in the same campus, just 100 meters away. We test him, the PCR test is done, a complete questionnaire-based history is taken, and very important, which I need to mention, is the test for the attendant. All of us need to test the attendant also. It is a possibility that we just test the patient while he comes with an attendant who is COVID-19 positive. So we do not permit more than one attendant inside our hospital. We test both the patient and the attendant, first with the gene expert, which is a TrueNet, which gives faster result and highest negative predictive value, followed by compulsory mandatory 3-gene RT-PCR testing for the patient and the attendant. Then once they are cleared free, this duration takes around 3 to 4 hours. They are admitted inside the hospital. A detailed evaluation of the patient is done, and as I said, CT chest is a very important part of our fitness before he is taken inside the operating room. The healthcare professionals are also tested. They have to be COVID negative on RT-PCR 3-gene test with a complete questionnaire for their own symptoms, which is done daily. Testing is done in 15 days. So this is as far as the healthcare professional and the patient is concerned. The theater etiquettes are very different from then when we were in the normal days. Now we have N95 mask for all, even the COVID negative patients, the shield for the cover the face and the eyes, and along with that a complete personal protective equipment. So this is what we follow. We have smoke evacuators in our theaters, but as Dr. Prager said, we need not spend too much for smoke evacuators. We can go for a 1% sodium hypochlorite solution with a routine filter and evacuate the smoke through that. So that's what we are doing at this point of time. When we discharge our patients, we tell them that you have to quarantine at your home for 15 days along with your attendant, and then get a repeat swab test and send us the report. Inform us if you come in contact with any patient who is COVID positive immediately, so that we can get you tested and quarantine you. That's what we follow.
And as far as energy sources intra-op, do you?
We are routinely using the ultrasonic scissors. We have not changed with our energy sources as of now.
Okay, great. And I know Dr. Bandari surpassed one of the questions that I had to him, but I'll go to you, Dr. Prager. And now, I know you're operating in a COVID-19 negative facility, but would you operate in a COVID-19 positive facility? And would your approach be different to patients intra-op?
I think if you consider operating in a hospital that treats COVID patients, there must be the guarantee that there is a strict separation, not only of patients, but also by staff and all the equipment, all the infrastructure. So actually, you must make a hospital in a hospital or an own department. So I consider this very, very difficult, to be honest. Otherwise, oil and you will have some contamination.
Yeah, definitely, it's a risk. Now,
yeah.
When you discharge your patient, what's your approach on discharge?
Yes, they have to quarantine also for 14 days, and of course, social distancing, wearing masks for nose and mouth are usually in Austria. Everybody has to wear that in public. So this is our recommendation for these patients. For all.
And do you test them prior to discharge as well, or?
No, because the hospital stay is not so long. As I mentioned, we test them on the second day. So this is usually the day of discharge. So you can now, all patients that are admitted to the hospital are tested for a second time after 48 hours. So this is usually when we discharge them.
Okay, great. Dr. Bandari, I know you're operating in a COVID-19 negative facility, but would your recommendations be any different than Dr. Prager's on operating in a COVID-19 positive facility or facility that treats COVID-19 patients?
See, I don't think that separation is possible. I agree with him. And at this point of time, what our administration has done is that they have divided hospitals into 3 categories. There is one which is a red zone hospital where only COVID-19 positive patients are admitted. There is one which is a yellow zone where COVID suspects are admitted. The moment you have a COVID suspects which turn out to be positive is shifted from yellow to the red zone. And the one which are the greens are the one where we work. There's absolutely no chance you can have a COVID positive patient because you investigate them immediately prior to admitting into the hospital and you do only elective procedures in these centers. All the green zone hospitals, if report any COVID positive patient by mistake, have to be sealed and the staff has to be quarantined. So I personally think that for hospitals to admit both the sets of patients, both COVID positives, COVID negatives, and then to do surgical procedures, at this point of time, I think it's full of risk. And I think we should refrain because there is always a possibility of infection.
Okay, great points. And I'll go to the panel and I'll go to Dr. Brown first. So is your approach any different than Dr. Cow on testing patients?
No, it's very similar. We simply don't have enough tests in the country. With these rapid PCR tests, we've got 18 in my whole hospital. And so we're reserving them for people who come in who are unconscious or who have a situation that we really need to rapidly know. We can now get a turnaround of about 6 hours for the normal Roche test, but that's about as good as we can get. And at the moment, we're not doing routine testing, and I don't see us moving towards that because of the concern of the false negatives. And we're not using any special precautions in theatre. In fact, our biggest issue is we can't get level 3 surgical masks. So we've now been using level 2R. So level 2R is flash tested to 120 millimeters of mercury, whereas level 3, which is our normal Australian standard for an operative mask, is 160 millimeters of mercury. There's a nationwide shortage. And so we're restricting them to people who are over the wound now. And anyone else in the theatre has to wear the level 2Rs. which tend to have the ear loops, which aren't quite as comfortable to wear. But so they're the sort of, and we're running out of surgeon gowns. That's the other thing we're running out of.
Oh, I hope things will change soon. But
Yeah.
what are the tools that you're using to define risk? For example, us in our facility, we're using a chest X-ray PCR and a CBC as an example, just to delineate how we deal with the patients further. What's your approach within your shortages?
It's a temperature. We take a temperature on everyone, and there's a structured questionnaire. So it's about risk factors and symptoms. But we are operating in an environment where the community rate is very low. We're a country of 25 million. We've had 7,000 cases. The point prevalence in the community is 1 in 100,000. So it's very low. Yeah. So the risks of doing CTs on everyone routinely is probably higher than the risk of missing a PCR. Missing, sorry, a COVID, I wanted to say, yeah.
No, understood. Dr. Himpens, so what's your approach within your practice? When do you test patients? How do you deal with things intraoperatively? And when you discharge patients?
Well, as I mentioned, everything is pretty much back to normal. And in terms of quarantining patients post-operatively, I think that's a little bit overkill. I mean, I can accept that when we're at the peak of the pandemic, but right now, Dr. Prager said there was like 50 cases a day now in an 8 million population. We are about 48 cases, I think we had today, in an 11 million population. So, and also, I don't think the Belgians are disciplined enough to accept that once they go home, they will have to quarantine themselves and all their acquaintances. This being said, I must say that all the patients still, when they're admitted to the hospital, they must wear masks at all times. They cannot be accompanied by anyone except on the pediatric ward and in the maternity ward. And the length of stay is pretty much unchanged in comparison to what we had before the pandemic. And in terms of testing, we don't test the patients on their way out. We don't do that. They're extensively tested before the procedure, but not after the procedure, provided, of course, they have none of the obvious symptoms of COVID.
Okay, great. So let's see if we changed the audience opinion in presenting, in dealing with patients and testing with patients and intra-op precautions. And meanwhile, I'll go to Hazem.
Not much to say, Ahmad. There's only the point about the use of ultrasonic devices during the COVID pandemic. There are some theoretical risks. There's nothing substantial to support these fears or concerns. All the published evidence would say that you have to use them with caution, but everyone is focusing about the point of smoke extraction. And I think this has been covered really well by the panelists and speakers. So other than that, nothing to add.
Thank you, Hazem. So let's see what the audience think, or if they change their mind, and we'll go next to taking. So 59% precautions with testing to all patients on 1 day prior to surgery, and 14% will do testing but unsure of timing, and 10% would test on the day of surgery. So with that, let's see if the audience has any questions and take them meanwhile, and we'll do a summary of the guidelines, and happy for anybody to add any points at this point while I look over the questions.
I just wanted to ask Mohit, how many of your patients that were PCR negative and had a positive CT scan turned out to be really positive later on in the PCR?
Yeah, so we never had this. In fact, to be very honest with you, if we had one such patient who was PCR negative but had findings on chest CT, we did not proceed further with that patient. We referred him to a yellow zone hospital, but later turned out to be again PCR negative. To be very honest with you, PCR has a 60% predictive value in terms of whether you declare, and plus I could tell you, because now I know about this, there's a cutoff mark where the RNA amplification is being graded to be positive or negative. It's different for different countries, different for different public authorities. So there's a lot of gray zone there. So what I would say is that my personal take is a combination of a gene expert with PCR with CT chest, and if any one of them is a little bit dicey, refrain them from entering your operating room, at least for now.
This makes a lot of sense, but to summarize it, also your experience was the same as we had in Vienna, and the CT scan did not improve the predictive value of the PCR.
Anything which is taken in isolation will not improve. We have to combine sort of a history taking, the history of contact, the clinical signs and symptoms, and then only, and then also we are not 100% sure. You know, that's the tragedy here. It's not like HIV where you have that window period. It's like anything, you can range from. So there is a problem there, but we have to start working. So we need some baseline to work. Something about the gene expert, I think it has got a very, very high negative predictive value. Very interesting. I had two such patients who turned out to be positive on a gene expert, turned out to be negative on a RT-PCR, and had no finding on the chest CT, were operated. So this is happening. So I think.
How expensive is this test, Mohit? How expensive is this test? Is it comparable to PCR?
Yeah. So in our country, it's not very expensive. So a PCR is around, you can say PCR test would be 3,000 Indian rupees, which is around how many dollars? It's around $50 US in India, and that too because $40 US, and that too because our facility, specifically the lab, is being run for a COVID hospital, so they have subsidized the rate. So it's 50%. So we pay a price of around $25 US for the RT-PCR and gene extract, or what you call as gene expert, and another 15 to 20 US for a chest CT. It's pretty cheap here to screen these patients, and government is kind of very helpful because they don't want us to do elective procedures without screening. That can be a disaster. So they want us to screen all these patients, and they're helping us out of the way with the kits, and it's a huge supply here.
Okay, thank you so much.
Those are interesting points, and the discussion was very interesting, and you answered several questions within that discussion just by itself. The point, one great question that one of the attendees asked: how do you approach that increased cost of preoperative workup within a bad economic situation? We're doing testing, CTs, a lot of stuff preoperatively to address and treat those patients. I'll take Dr. Bandari if you want to start first.
Yeah, so I think we have to see the logical, we have to come to a logical sense here. We see, I know it's a cost, and I think that cost, but we have not increased our prices for surgery. In fact, we are thinking of decreasing them further to have more patients gain the benefit of bariatric surgery. I personally would feel it's a very bad economic situation. I understand that, but it's a time for us to think about our own safety. Now imagine you start to take these patients without doing this preoperative workup just to save the cost. I have at least a 5 publication in my hands now which says that if you are doing it without preoperative testing, you will see the disaster, because most of them are asymptomatic patients. So we end up having a patient who is not tested to save the cost, and we end up coming in contact during laparoscopy or any elective procedure with a COVID positive patient, infecting our entire team, and then sitting at home for 15 days in a lot of anxiety. I think it's not worth the money. I think all of us have earned enough. It's the time to give it back to the society and to work. And I'm not concerned about myself alone, but I work with a team of 50 people here. If I have a patient who is COVID positive, and God forbid, and he infects somebody who is in a lower strata who cannot take care of himself, my nursing staff or somebody, I have a big moral obligation to fulfill. So I have already paid the hospital from my own side, and all of us can do that. These tests are not going to be so costly. So we can, devote a part of our practice for personal protective equipments for our staff, testing our staff, and we are not increasing any pricing. In fact, we are putting money from our side. And again, it's my personal view. I'm not a philanthropist, but I have a moral obligation to fulfill.
Agree with your point of view. Dr. Prager?
In Austria, you have the public hospitals. There, of course, the hospitals pay for the tests. You have some small private hospitals, and the patients going there have additional private insurance usually. So in this case, the private insurance covers the additional costs for the testing. Concerning the higher costs for PPE are covered by the private hospitals without raising the prices for the surgery.
Okay, great. And panelists, Dr. Hempens, how do you view the added cost to the preoperative workup prior, in consideration with the bad economic situation on the healthcare system in general?
That's an excellent point, because some doctors started charging their patients for the additional cost of PPEs and all the other stuff necessary for the diagnostics. But there's been a law that came out 3 days ago that we're not allowed to charge anything to anyone for those added costs. So who's going to pay for it? Nobody knows, but it certainly will not be the patient.
Definitely. Dr. Cal and Dr. Brown, any thoughts? I know your country is facing a lot of shortages, and that's why probably you're not restarting fully 100% depending on where you are. How did the country tackle the issue of cost and restarting, and when did you decide to restart based on the shortages that you have? I'll start with Dr. Brown.
I guess the government drove a lot of it. So we have a federal government that we're a sort of federation of 7 states, and each state has their own sort of healthcare system, but the federal government or our Commonwealth government said the advice from the chief medical officer was that the curve had gone down, that we didn't need to preserve our PPE stock for ICU anymore, that we could start to free up operating theatres that were being on hold to turn them into ICUs, because we had the benefit of unfortunately seeing what was going on overseas, and so there was an anticipation that we'd have to turn our operating rooms and our recovery areas and day wards into pseudo ICUs. So we'd geared up to do that. And then when they saw that the curve was pleasingly not just flattening, but going right down again, they decided it was appropriate to start to free up the PPE resource as well as the physical space resource to allow some operating. And it's been a very graduated response back as we've been able to receive shipments of PPE from overseas. Our local manufacturers have ramped up, and also the community incidence has continued to go down. So I think the government has done as good a job as they can. They've all worked very carefully together. They've listened to doctors. They've taken a very cautious approach. We've had very aggressive isolation laws. We're only allowed to leave our house for 4 reasons. We've not been able to see anyone other than our immediate family members. And so I think the return to normality has been very much a considered approach, but now it's taking on a local flavour. So in Lillian State, where there is essentially no cases at the moment, they've ramped up more quickly because they don't feel they need to preserve the PPE at all, whereas we still have some in the background, and so we are having to take that on board, but we are still ramping up. The cost is borne by the government, so patients don't have to pay anything. It probably means we're going to have a very large debt that we will hand on to our children and to our children's children, but we have a public and private system, but in both systems the government is picking up the bill for the extra testing. The PPE is borne by the healthcare system as well.
And Dr. Cow, on your side, I know you're restarting 100%. How different, and when did the government allow you to start practicing? Did all the cases stop? Do you have a decreasing curve, ongoing cases, or no cases at all?
So when we had a period of no cases, no new cases for 2 weeks, the government felt that it was safe. So when we started at 25%, and then that quickly escalated within 10 days to 100%. Again, all our testing is covered by the government, so it's no cost to the patient as long as they meet the criteria. So the criteria is based on symptoms or having contact with anyone with COVID positive symptoms. And again, all our PPE is supplied by both the private and the public hospitals. So it's no cost to us, no cost to the patients, but it's borne by the hospitals.
Great. One question that one of the attendees had on table endoscopy, how difficult it would make your surgery with insufflating the bowel, and how do you deal with it to prevent the insufflation? I know I have it in my mind, but would go to Dr. Prager. If you were to do on-table endoscopy preoperatively, what are the techniques that you use to minimize the bowel insufflation?
Yeah, you must clamp at the level of the antrum or duodenum with a soft bowel clamp. That's the easiest way. If you want to do it more complicated, you can go for Treitz angle. Then this is another possibility. But the easiest is to compress at the level of the antrum pylorus, first part of the duodenum. But it's important. If you don't do that, your small bowel will become very huge and you have no more place to proceed with the operation.
Definitely. Dr. Bandari, and in those cases, do you use CO2 or just air?
Yeah, so you know something, I've been doing intraoperative endoscopies in all my cases now, and we have almost 5,000 cases where we did intraoperative endoscopy, and we use carbon dioxide in all our cases, absolutely no air. Carbon dioxide makes the job much more easier. Once you have this experience of doing intraoperative endoscopies, in our case, the fellows are doing it, we have trained them to put minimal amount of carbon dioxide. You don't need to just continuously keep your hands and put a lot of gush of air inside. Very minimal carbon dioxide, and more minimal when you enter inside the duodenum, just when you cross the pylorus. You don't even need to block it. I have been doing these endoscopies now. We don't get a lot of air, and by the time you start to do the supracholic part, all this carbon dioxide will be absorbed. So the first trick is use carbon dioxide. Second, you can clamp it. The third one, which is most important, is minimal handling of the tissue, minimal pushing of the air inside, and immediate evacuation of the air. And when you sort of do the practice of doing these intraoperative endoscopies, after 100 to 200 cases, you would find that there's not too much of air inside the bowel. You're able to manage in minimal amount of air.
Great. Thank you, Dr. Bandari and Dr. Prager. Another question is, if you're still having ongoing cases, would you offer bariatric surgery? Dr. Hempens, within your population, if you're still having positive cases, how do you decide to operate, not to operate, when? And what's the data in Belgium, and what does the public health department tell you as far as guidelines?
Well, you showed in the very beginning the graph of the progression of the caseload in my hospital, and most hospitals are like that. So we're back at 75% of activity. And actually, the reason we're not back up to 100 is that we got guidelines from the government that we have to preserve 25% of the beds and 25% of the ICU capacity for a potential second wave of COVID-19. Other than that, I think, as I mentioned, my personal view is that we have to start with lighter or less sick patients, bariatric patients, in order to avoid almost mandatory stay at the ICU. And also, I don't think we can afford at this stage to have a morbidity, not only for objective reasons, but also for subjective reasons. We don't want the public to get scared even more than they already are. And so I don't think we can afford complications now. So that's why I personally would be in favor of doing just lighter bariatric cases at this stage.
Okay. And in light of what you mentioned also, and another question from the audience is, how do you deal with a potential second wave now that we restarted all practices? I'll take your point of view, Dr. Prager, first. Do you think about a second wave, and what's the approach in Austria?
We have quite a different approach, as Jacques mentioned. We don't keep 25% empty, but we are able to switch to the status we had before quite fast. So this will take us only 1 or 2 days. And the capacity and the ICU, when you need it, you know that pretty before, because the new infection rate will increase, and maybe 4 weeks later you need the ICU beds. So you have some time before you really need them. If this will happen, of course, we will have to also reduce the capacity for our patients again. This is for sure. A second total lockdown, I think people will not stand in Austria, to be honest.
Yeah, I don't think anybody anywhere will stand in a second lockdown. But Dr. Bhandari, is the approach different in India?
Yeah, I think we should understand that these lockdowns were not done to restrict anybody, but the purpose of lockdown was to procure beds, ventilators, PPEs, and testing facilities. I think in India, our Prime Minister has done a fantastic job. I think considering a population such huge like we have sufficient number of beds now, we have sufficient number of ventilators now, and we are not dependent on anybody. We are producing our own PPEs inside our own country. And let me tell you, we have 500 labs all across the country, even at the district levels, which have testing capabilities for COVID-19. So I think even if India has a second wave, we're not going to have a lockdown now. We're going to survive this. Fantastic job done by our government with very limited resources, but being self-reliant on what we have in our country at this point of time.
That's great. I hope no second waves will come, but we have to think about it just in case to be ready. And what's the approach in Australia, Dr. Brown and Dr. Gao? Dr. Brown first.
I think the modelling we've seen is it's possible and probably probable that we'll get a second wave, and in Australia we'll eventually have to open our borders, and so that will increase our risk. But much as Gerhard was saying, the modelling we've been shown suggests that once we start to see the curve of incidents going up, there's at least a week's notice, that there's a lag time to needing a significant number of ICU beds. So we're describing that we're dialing up surgery, but we're also thinking that if we need to, we'll be able to dial it down pretty quickly. But that's, again, why, as we've reintroduced surgery, we've tried to do cases that don't necessarily need to go to ICU, just as Jacques was saying, because we want to keep that capacity there. But as we get more confident, I think we'll be able to do higher risk. We've not talked about revisional bariatric surgery at all. It's a big part of my practice, and I'm not doing it. I won't do it yet, because I do think the risk of we know from our registry that the risk of a complication is about 3 times higher. And so I don't feel that I don't feel confident enough yet that that it's safe to do revisional procedures where they may need a prolonged ICU stay. But yeah, the second wave is certainly in our minds, but I think we are fortunate that we will get that little lag time where we can prepare.
Dr. Cal?
I agree with everything that Wendy said. We contained the pandemic very quickly by closing our borders and practicing social distancing. And I think we're now in a position that if the second wave came, we are in a better position to deal with it because we've got PPEs, we've got enough beds, and again, the population is better educated in understanding the spread of this virus.
Great. Those are great points. There is a question on training, but I would defer that question to our previous webinar. Please go ahead and watch an entire webinar on training. It's on the Virtual Academy and the IFSO YouTube channel. Let me just summarize what we've discussed. I know everybody talked about the variations in testing and how they approached testing preoperatively in patients, but even if you have COVID-19 negative patient, asymptomatic patient, everybody agrees on risk assessment, and depending on where you are, you get a test on the day prior or prior to entering the facility. Everybody's in agreement that preoperative endoscopy is mandatory prior to bariatric surgery. If no endoscopy, no surgery, or delayed, and discuss other options. And procedure selection without endoscopy would differ in some of the discussants. And if there is no endoscopy, majority of us would just either go try to find an additional way to get information or postpone if there is no risk. And testing staff is mandatory within this time period if you have the testing ability and availability. And I'll leave closing remarks to each now. Dr. Prager.
Yeah, I enjoyed it a lot. I think this is a real challenge, the whole COVID crisis, but together, I think we will come over that. And thank you to all of you. I had a lot of input today, also for myself and my strategy. Maybe we will include that gene extract test. At least I will discuss that with our virologists. And so thank you, all of you.
Thank you, Dr. Prager. Dr. Bandari.
Yeah, something I wanted to bring to the notice, if you test very nicely and very effectively, the cost of the PPE is going to reduce. So either you invest on testing or you invest on very high level of personal protective equipment. But if you test very well, you fulfill a moral obligation, and then you require less PPEs, because if you are sure that your patient is negative, you don't need to, go to level 4 PPEs. Number 2 is, which is very important, is that we need not change the principles of bariatric surgery just to accommodate a pandemic. But I enjoyed thoroughly the entire panel, and I learned a lot from this. Thank you.
Thank you. And I think before we proceed to the panel, Hazem has a question. Please go ahead, Hazem.
Thank you, Ahmed. Sorry, quick question. It seems that we're in agreement that when someone has had the surgery and they've gone home, we advise them to home quarantine for 2 weeks. But these are patients or individuals that we know are negative. Are we protecting them, or are we protecting the society from them? And if we are protecting them, why the 2 weeks? Why not the usual 6 weeks post their operative recovery?
Dr. Bandari, would you like to start?
So I think 15 days quarantine, our reason for doing it, our institution, is medical legal. What is going to happen is that most of these patients we will operate might come in contact with a COVID positive patient, get the infection, and might claim that we got it from the hospital because of bariatric surgery. Now, if you ask them to quarantine 15 days and they do it, and you have to believe them. You have to go on the face value they do it, and their COVID test after 15 days of surgery and quarantine is negative, which means that they did not got it from the hospital. So I think here I'm talking about a medico-legal liability, number one. Number two, I'm safeguarding the interest of the patient, because immediately post-operative, even if there is a little bit of decrease in the immunity levels when the patient is adjusting, he, if does not expose himself to people outside, it's always better for him. In any case, most of these patients take rest for a week. They can easily home quarantine for at least 15 days. Some of my patients, because they come from outside, they stay in the hotel in our campus to quarantine for 15 days. And these facilities are available across the bariatric centers, I understand, where cheaper options are available for them to quarantine, recuperate, and also fulfills a medical legal obligation.
Dr. Prager?
I think it has a lot to do where in the curve you are, whether you are at the peak or whether you are at the very end. If you have such low new infection rates as in Australia or even in Austria, I would consider, I find it not mandatory anymore to quarantine the patients for 14 days. If you do that, it's clearly to protect the patient. And of course, the question is valuable, why don't you do it then longer? I think the patients simply will not stick to that, to quarantine themselves for 6 or 8 weeks.
That is true. Dr. Brown, closing remarks, and if you have anything else to add.
Oh, look, I just want to say thank you very much, Ahmed, for organising such a fantastic event. And I feel very humbled to be sitting on a panel with such experienced people. I am sorry that your communities have experienced such loss with this COVID crisis, but I thank you for sharing your experiences with us. And, you know, I think we've all learned a lot from it. And I think there's things that in my practice will have changed forever because of COVID. But I do want to just acknowledge you all and thank you so much for sharing your wisdom with us.
Thank you, Dr. Brown. And we're privileged to have you as an expert panel as well. Dr. Hempens?
Well, I must say that I was very surprised by how things are different in the different countries of the world, but still, I think that the baseline is the same. We are looking for, and we continue, even though in a pandemic, we're looking for the patient's well-being, for the staff's well-being, and we're still, I don't think, we're not trying to change the world in terms of bariatric surgery. We try to continue doing our job and not give in with panic like we see in some other disciplines. So I really think we're doing a pretty good job all across the world. And I thank you for the opportunity to share with you our experience here in Little Belgium. Thank you.
Thank you, Dr. Hempens, very much. Last word to our president.
Well, this is our 5th webinar on COVID since the pandemic, and with each webinar, I have been so surprised by the depth and the width of the discussion, and also the speakers that have come on so willingly to share their expertise as well as their time. So for tonight, I thank Gerhard and Mohit for sharing their time with us, and of course my 2 co-panelists, Wendy Brown and Jacques Hempens, for sharing their expertise as well. Hazem, it's usual, you've been a very good fact checker. You've been doing this for a number of webinars, and you did a great job again tonight. And of course, to Ahmed, you've been a great chairman of our committee leading this webinar, and I thank you personally for your enthusiasm and for your continued willingness to participate in our webinars. And of course, I'd like to thank tonight Medtronic for sponsoring this, and also to all our attendees who have showed so much interest with our webinars and for their continuing support to IFSO. So thank you, everyone.
Thank you, Dr. Cao, for the great words. And would like to remind everybody this is recorded on the Virtual Academy IFSO YouTube channel. Please spread the word, share it with others. And our next webinar will be on the 29th, and we'll discuss patient relation issues and fears, and will be sponsored by Johnson & Johnson. Thank you, everyone, and till the next webinar.
Thank you.
Thank you.
Keep safe, everyone. Bye-bye.
Thank you.